I'm Antoni Chan, consultant rheumatologist from London, United Kingdom, and I'm here in EULAR 2023 in Milan, reporting for Room Now. During this conference, there has been a lot of advances in the understanding of machine learning and also artificial intelligence and how we can use it to improve our diagnosis and also management of our patients. And tonight, we are very privileged to have Professor Thomas Hugle from the University of Basel in Switzerland, who has very kindly come along to discuss one of the papers that he presented at EULAR 2023. This is on the use of new techniques to look at imaging and to help us to get to a diagnosis. So Thomas, welcome to Room Now. And we'd like to welcome you and also to discuss some of the work which is really groundbreaking, in particular poster 0892, where you describe a new technique for us to use some of the advances in machine learning for diagnosis of a large number of patients, more than 10,000 patients in your study. So if you'd like to tell us a little bit about the work and how you see this going forward. Thank you.
Yes, thank you, Antoni. It's a great pleasure. Thanks for inviting me. So in this poster, we actually don't describe a new technique. It's more we test an end-to-end platform, a no coding platform. So we have a large data set in patients with hand osteoarthritis, and we scored in total over it's 49,000 DIP joints, so the end joint of the hand joints, right? Osteoarthritis. And in this work, we used a no-coding platform. So we asked ourselves, we can write a code, a convolutional network to detect osteoarthritis on these hand X-rays that we scored, but can we also use a no-coding platform? So this is it's people speak about a no-coding revolution. Maybe it's too much, but the idea is that you use those platforms, you upload your images, you segment your images, you tell the machine what to do, and then the machine would basically do the training for the machine learning model, the convolutional neural network, on its own. And this is what we tested in this large data set. And it worked. So we actually created two models. First was a segmentation model. We taught the machine this is a DIP joint. So the machine was quite performant to identify those joints on hand X-rays. And then we trained in all of the scored joints. The model is this Kelvin-Lorentz score 0 or 1, 2, 3, or 4, which would be advanced osteoarthritis. And the result was quite promising, I have to say, with a sensitivity of around 80% and a specificity of 85%. And so I think that was quite good. So it was the accuracy was 86%. And I think that's promising. What we also learned is that it works better to detect no osteoarthritis or grade 1. It works well to detect advanced osteoarthritis. It's a bit weaker in the states Kelvin-Lorentz 2 and 3. There are some confounders, but other than that, it worked quite well. We did not stop there. We actually then, within this model, this end-to-end, this no-coding platform, it also creates you an application, a user interface to test your images right away. So we used it as a rapid prototype, and we asked radiologists and rheumatologists, do you like this application? Do you like that the machine could help you detecting the grade of hand osteoarthritis? And the result was that rheumatologists liked it. They said, yeah, it's quite difficult, this scoring of hand OA, the joint space comes back and quite complex. So we would like assistance by a machine. And the radiologists said, we don't like it. But what we like is the heat map. And we also created so-called heat maps. And that's very interesting because radiologists, and by the way, also pathologists, they love heat maps. So heat maps are those, pictures, those colors on the X-ray that show you the region of interest. It shows you where the algorithm took its decision. So it takes your attention. And this is, the case in hand X-rays like here, but also, for example, in slides for pathologists. So radiologists really like this. And I think that will be the first application that we see away in clinical, the machine learning models in clinical practice is that we would have the scoring, but also the heat map, showing us where we should look and I found this quite interesting. That was a learning for me.
I think it's a huge development. There is a lot of manual time spent trying to create these X-rays manually, and if we can move towards a more automated way, which also gives us the grading and the classification in a very uniform way, I think that will certainly help advance the management of the patient. Where so you've done osteoarthritis, of course, you will be doing more validation. Do you see this applicable to, say, rheumatoid or psoriatic arthritis, some of the other inflammatory conditions?
You can do it with every image, right? And so you just need label data, but definitely, I'm not so sure whether with this no coding platforms we can go to production, but we can test it and we can ask actually every question we want to ask a machine learning model. So I think it will empower clinicians to ask questions and develop early on machine learning models to get the right answers from this machine learning model. So yeah, I think it can help also in RA or other diseases.
Yeah, because sometimes it can be quite challenging. Take, for example, a patient who has conditions in the DIP joints, and you wonder whether it's more osteoarthritis or more psoriatic arthritis. And a lot of work has been described in the MRI field to kind of help us to understand. Do you see if, if you did large numbers and you went through a lot of these radiographs, would there be a place to help make some differences between, say, OA and psoriatic arthritis?
Oh, that you touch a good point. I mean, that's a persisting problem in clinical practice, and
Yeah.
sometimes it's hard to differentiate between PSA and OA. So I think the 50,000 images that we scored and trained the model, it seems to be quite confident to recognize OA. We haven't done this for psoriasis arthritis, but definitely it would be good to see whether, to differentiate. So that will be the next step. Here, I think it could help the clinician to differentiate between the two, because as you said, sometimes it's very difficult. That would be the next step we're going to do, Antoni. It's a good point.
Yeah. I mean, we rely on what we know. So, osteophytes or new bone formation, certain changes, but those quite labor intensive for us to do by asking the radiologist. So if that can be done, or at least checked by a machine learning process to bring out those who are very clear that they have a certain phenotype, and those maybe in the between we would get radiologists to check. That in itself, I think, will help reduce some of the delays that we have in reporting some of these scans.
Definitely. And then there's another application for example, clinical trials. If you have large clinical trials, it could be helpful also to have a scoring from the machine. As I told you, it was a bit more difficult between KL2 and KL3, which is actually the grade we are focusing in clinical trials. So that could be a problem. Still, I think it's interesting also maybe to see if patients are eligible to go into a clinical trial. Here I see also some options.
Yeah, I think standardization, and also independent reading could, there'd be a place for machine learning to take over to improve the uniform reporting of some of these scans in clinical trials. Here at EULAR 23, you've also been very involved in some of the other seminars and talks on in the field of digital. What do you think? Were the kind of key highlights, certainly for you at this meeting in terms of this field, and particularly in the field of, say, imaging and machine learning and AI? Were there any sort of highlights building on from your talk here?
Okay, so I mean, first of all, I was surprised how many AI talks there were compared to last year. Well, there was still the pandemic, but there are many more. And as you said, imaging is probably number one. But remember that we have over 500 FDA-approved algorithms, and most are in radiology and pathology. So, this is the practice already. So it's already normal, right? So sacroiliitis is probably number one because it's a difficult joint. It needs a lot of expertise and, you know, to estimate the volume of bone marrow edema, etc. So I see this as very interesting. But there are also other applications. So most were in MRI. There were also some abstracts about recognizing hand erosions, for example, and synovitis in MRI. I think that will go straight into clinical practice, and there will be new FDA-approved algorithms. That's for sure. But there are also other applications. I presented some work on clustering, so the unsupervised learning models that you don't label the data, you just give the machine, kind of the raw data. And for example, for phenotyping or clustering, we did this for fibromyalgia. I think it's very useful for heterogeneous diseases like fibromyalgia, lupus, for example, or others, where the machine can help you to define phenotypes, which was very helpful. For example, we learned that variables like childhood and adolescence pain is very important. Also, some psychotropic drugs, or even living alone or in a couple was quite an interesting or an important variable to cluster fibromyalgia patients. So I think it helped me also clinically here. Other abstracts I saw were on language models on NLP, mainly to help to do with the electronic health record, because I mean this is the number one data source. Imagine all the data and the billion of data points and patient encounters that are available in electronic medical records, and here NLP plays an important role also to develop models to diagnose or to display patient journeys. I found that very interesting. There was some work on language recognition and know how that would identify maybe your mental status. I found that very interesting. There was not so much, for example, on drug choice, so on clear clinical decision support. So there were some work on the disease prediction. So if you wish, this is somehow a clinical decision support. There was no work, at least I came across, that they really said take this drug or this drug. And so maybe you can predict, for example, methotrexate non-response. More than that, that was not really a clinical decision support, and was, I think, not so much ChatGPT. I expected much more on this. I don't know whether you saw some abstracts on this topic.
No, I think we were perhaps it was a timing issue. By the time of the submission of the abstracts, we were kind of getting into the whole Chat GPT, and I've seen you've written a very nice review recently. And I think what we're discussing here, all the points that you raise, are it's going to be something that's going to feature more and more in the conferences that we are going to attend probably for the next few years, in terms of how machine learning is going to affect the whole patient pathway. And we discussed today about imaging, but if you had seen today, there was also work on prediction of people who suspected who have inflammatory arthritis from the undifferentiated arthritis. There was a nice presentation yesterday, and the accuracy is about 80% in people with UA or clinically suspect. And they look at features, and the machine learn how to predict those who became rheumatoid later on. Then there was the abstract on the MRI, using the MRI to read, and more than a third of it was accurate. And then you got biologic switching, moving from originator to biosimilar, and also looking at long-term survival. So I feel that we are on the cusp of more and more of these type of work coming along. And so I think it's certainly a rapidly expanding field. But one of the things I think you raised before is the importance of standardization, the importance of some form of governance about doing all of this. So, what do you think about, as this rapidly expand? Should we be excited, or should we be a bit fearful or cautious? What would be the best approach in your experience so far?
I think that AI, provides how do you say, benefit in little pieces. We know this from the cell phone, right? For example, image recognition. It recognizes my face. That's nice to have. It's not a game changer. So I think AI will sneak in our clinical practice. First, it will support a little bit of image recognition, which is already the case. I receive radiology reports with note supported by AI. That's already there. And then it will maybe support with disease prediction. So, for example, the electronic health record will have little flashes going up or down, showing predictions or trends. So we will maybe work with trends of laboratory values, for example, and it hopefully will save us time, for example, discharge letters, etc. Here I think of ChatGPT. So I think it will really sneak in, and then we will use to it, and don't want to miss it.
Yeah, I think it's certainly exciting times, and one of the issues that we face is the workforce shortage that we have in our field. Is the demand is outweighing the capacity. So to bridge that gap, there must be certainly a role for technology, and how we apply that in not everything, but I think in certain things where it's very quite labor intensive or very repetitive, where there's an algorithm built for that. And those are, I think, ideal places for these sort of technologies to be used. But I don't think it will replace the doctor-patient relationship, not yet at least.
No, but think also of patient empowerment. So it would help probably patients to, take simple decisions or other decisions. I think AI can help patients who maybe don't have access to a rheumatologist or want to have a second opinion. I don't think that AI will be gold standard. For example, like in chess, right, where it outperforms the human. That's not the case. So in most of the models, they are supervised, meaning they learn from human experiences at the end of the day. And so I think, it won't replace humans. I think
Yeah.
so. So not radiologists, neither.
I think it's a really exciting. We also had a good session today on apps and how we can prevent the sort of the loss of engagement long term, the importance of constantly evolving, making sure it's fit for purpose. As technology evolves, it needs to kind of meet the demands of both the patient and the clinician. So I think it's a very dynamic field, and this is what I think we will continue to see in the conferences that we will kind of come up against in the future. So what will be your key takeaway from EULAR for you in terms of this AI, GPT, ML? What would be your key takeaway from this conference?
So AI is here to stay. I would say it is here to support us, to empower us. Um, I don't think there's a revolution, like protein folding, which was, in other fields. But I think it's there to stay. There are more talks now and more sessions about digital solutions. So I think what we need now is literacy. It's education on all of this. I see this as a take-home message that all of these technical advances they're great, but we should not forget to train people and educate people, both patients, care professionals, and rheumatologists, to keep on with this technical innovation. Only in this way we can leverage quality of care.
So continue to engage and continue to embrace the new technology. So Thomas, thank you very much for your time to share some of your key insights. It's a rapidly expanding field. Really good to hear your views of using this in a practical sense in clinical practice in the future. So thank you for your time. So this is Antoni Chan reporting for Room Now. Loved a great presentation from Thomas, and we look forward to future work from him. Thank you.
Bye-bye. Thank you so much, everybody.
Thank you.